Just whilst we are waiting for everyone to arrive, though, I should note that this is the first session in the Jean Monnet Centre of Excellence based in Manchester for the year. The centre, Dimitris, I don't know how long it's been running for now, but Professor Dimitris Papadimitriou, how long has it been running for now?
Well, welcome everybody as well. The centre has been running for nearly 20 years now, and over the past decade at least that I am actively involved with it, has hosted a very large number of seminars, as well as 4 prime ministers who came to speak to us in different times. The centre always values policy relevant research, and our seminars are also a way of us of engaging with problems of the modern world, of all things European, not always European Union, but certainly all things European. So a very warm welcome from me. Paul, over to you for the introduction of the speaker.
Absolutely. So it looks like we've got 34 in the room so far, and I welcome to you if you've just joined. My name's Dr. Paul Tobin. I'm a senior lecturer in European politics at the University of Manchester, and I'm also co-director of the Jean Monnet Centre. And today we have a fantastic speaker to welcome us into the start of our new year. Professor Jon Pierre from the University of Gothenburg. He's also a professor at the University of Melbourne and an adjunct professor at Pittsburgh University. If you go onto Google Scholar, you'll see he's been cited over 23,000 times, which is truly incredible, showing his impression within the research areas of public policy, public administration, institutions, multi-level governance, local government, Swedish politics, and many others as well. And so certainly those of you who are on my second year course, European Politics, will be familiar, or will be more so in a few weeks as well, with his handbook on Oxford's handbook on Swedish politics. But today he's going to be focusing in on Sweden's response to the COVID-19 pandemic. And it is a real pleasure to welcome you today to Manchester virtually. Jon, thank you so much for joining us.
Well, thank you so much for having me, and thank you for the invite and the opportunity to talk to students and faculty at the University of Manchester. It's a great honor also to kick off this seminar series. So thanks very much, and thank you, Paul, for those kind words. Okay, so I understand that the format is that I'll be talking for about half an hour, and then we just open up the virtual floor for questions or comments or discussions. So I suggest we just jump in. So let's go in. I mean, as we all know, a good part of the reason why Sweden has been the focus of so much attention during the corona pandemic is that we chose a distinctly different path or a different strategy to addressing the virus and the pandemic and the spread and the whole sort of containment strategy. Well, so we thought, I mean, I'll be making a point earlier that we ended up being pretty much in a category of our own, but maybe that was not the way it was originally intended. So let me circle back to that. But as an outlier, I still confess that when I was first asked to write this paper, it's for a special issue of policy and society. When I was first asked, I mean, Sweden was still the outlier, but the significance of that choice and what has happened since, if you just look and say over the past 3 months or so, has raised some really interesting questions about whether there is a level of convergence among different strategies. Countries seem to be constantly observing each other and sort of copycatting ideas and solutions and strategies from each other. Let me walk you first through some very basic facts. It's a population of some 10 million people. The current statistics say there's a total of 103,000 cases and about almost close to 6,000 people dead from the coronavirus. The spike was in say around April, I guess, March, April, a bit into May, and since then rapidly decline. What has happened since then is that we're not looking at a complete second spike or a second wave, as we can see in many other European countries. What we're looking at, interestingly, is that there are now different cohorts that seem to be spreading, catching the virus and also spreading it. So in the initial wave, the typical person catching the coronavirus would be people in their 60s or 70s, often people in nursing homes. I'll be talking more about that later on. Now, what we see are basically millennials, people in their, between 20 and 35, perhaps. I think particularly between 20 and 30. And there's been a fair amount of finger pointing here, looking at people on university campuses, interestingly. So we're still trying to figure out exactly how to deal with that. It's one thing to deal with people who are in nursing homes, but dealing with people who are in their 20s or early 30s is a different ballgame altogether. So we chose not to lock down. The argument was that it's not sustainable. It is a strategy which it does have the advantage of buying you time. I guess in part to figure out exactly what you're up against. You know, what are the fundamental qualities of this virus? How contagious is it? Is there a thing such as the asymptomatic spread or not? So locking down has that one big advantage, but as many European countries can see today, there are also significant downsides to that. There's the lockdown fatigue, which now is a big issue in many countries, and that may actually mean that when you know, a bit down the road, when you realize that now would really be a good time to lock down, you will find that there's much more opposition to that policy now than there was, say, in March. Back in March or even late February, there was a big understanding that, well, this is a really nasty virus, and if the government says that we really should lock down, then that's probably the proper action to take at this time. But to have people who have been locked down for a considerable period of time, and then now being sort of locked out again and telling them to go back into lockdown, that is a strategy which is likely to, and we see that already, which triggers significant opposition. So the Swedish strategy was basically to keep the primary schools open, to emphasize that, you know, daycare centers should be open, to keep the industry open, at least initially, and to let society function as good as possible under the circumstance. The key objectives was two basically. One was to protect vulnerable groups, groups that were likely to come down with the virus, and also, secondly, to flatten the curve, to make sure that hospital did not hit capacity and that there would be a steady flow of patients through the system that could be treated and accommodated by the healthcare sector. Those were the two sort of publicly stated goals. There was a strong initial recommendation for people to stay at home. If you can stay at home, you should do so. If you can work from home, that is also what you should do. One thing that has gained, I guess, most of the international attention has been the way in which government agencies sort of proceeded to ensure that these rules were followed. And the basic idea was to issue these directives as very general recommendations. So there was no saying that here are the recommendations. If you violate any of these rules, we will fine you or we will throw you in jail or anything like that. That was not the pitch at all. The pitch was saying that, you know, use your common sense. Oops. Okay, here we go. So use your common sense, wash your hands, avoid, you know, close social contacts, avoid, big congregations of people, and so on and so forth. But use your own sense of judgment. Do not just wait for government to issue very specific rules and enforce them with some power, but think for yourself. I want to walk you very quickly through the institutional setup here, which has also been the focus of a lot of attention. The central government staff, the government departments, is by any international comparison a really small organization with only some 4,600 people. That's across all the government departments. On the other hand, the agency system, the executive agency system, is significantly large, with more than 220,000 people working in 340 agencies. So the gravity of the system in a way is not with the central government so much, but it's more with the agencies. Secondly, or thirdly, there are 290 local authorities, well-built local authorities, properly staffed, properly financed, and so on. One of them, in this particular context here, their main task is to deliver elderly care and to run nursing homes. There are also 21 regions. Their main assignment in this context is they are in charge of the healthcare system. Now, what makes the system interesting is that, first of all, the agencies enjoy considerable autonomy in relationship to the government departments. So governments can only issue very broad ideas. They can give agencies mission, they can fund the agencies, which they do, and so on and so forth. But it's very hard for government to intervene in the daily operations of the agencies. Secondly, subnational governments, the local authorities and the regions are autonomous, both in relationship to central government and also to the agencies. So this is what sort of makes the system kind of fascinating to observe, even in fair weather sailing, as we say on this island where I live. Even in fair weather sailing, the system is really complex, with almost satellite-like structures, like the agencies, like the local authorities and the regions. Hence, there's a tremendous focus on coordination. And if time allows, I'll be sort of circling back to that later on, because I think there's an interesting story to be told. Paul, why don't you give me a holler when I get to like 25, 26 minutes, right? So I see how I'm doing. Here are some highlights of the Swedish COVID-19 strategy. First of all, in terms of the sort of management and the leadership of the political and administrative system, there was a very clear commitment early on from the Prime Minister saying that we will listen to the experts. So we're not going to micromanage the system at all. We'll be taking the back seat, and we will let the people in the public health authority and the state epidemiologist in particular, I guess, tell us what they think we should do, and we will certainly listen to their advice very, very carefully. There was a focus on protecting the elderly and the fragile, to flatten the curve, as I said. Those were the two key targets. In terms of social mobility, just moving about, keeping the city open, that remained the commitment very, very strongly. Let the restaurants be open, let the bars be open. There was a requirement that, well, you should be seated. You need to be seated if you're having a drink, for instance. There should be some clear space between tables and seatings and so on. But overall, no complete lockdown, but just urging people to if you can stay at home, do stay at home. Use your common sense, Apart from that, let things roll on to the largest extent possible as usual. There was a cap on, say, more than 50 people were not allowed to have in meetings. Other than that, observe social distancing, maintain good hygiene, use your common sense, and so on and so forth. So overall, if you look at this sort of comparatively, I think what you'll see is that there was not at all the same political or administrative or professional idea to intervene in social behavior, but rather to let people use their own sense. And this has actually been sort of brought forward as a good part of the explanation as to why Swedes' institutional trust during the pandemic has increased. Whereas in other countries, you can see the exact opposite pattern where people have become very critical towards the public health authorities, and they really sort of question their judgment. In Sweden, we see the opposite pattern. And the explanation that I've seen to that is that essentially, if you allow people to not just to sort of take directives from above, but to be given recommendations and then apply your own sense of judgment for what is okay to do for me now and what is not so good, that means that you will take a more positive view on those institutions. Now, what was missing here? What is not included in that strategy? Well, first of all, travel restrictions were conspicuously missing for a fair amount of time. This became obvious when people were returning home from ski vacation in northern Italy, not the sort of Bergamo region, which was one of the first really major hotspots here. They could walk in through the airport. They were not being screened or monitored or anything like that. They just walked in and they walked out into Stockholm or Gothenburg or wherever they were sort of coming in. There was no screening at all. Sweden even maintained an almost daily service with Tehran, which was another hotspot in March and April. There were almost daily flights coming in. Again, there was no screening, not even the most rudimentary screening in terms of, for fever or anything like that. No questions were asked about, had they been exposed to the virus when they were in Iran. Testing took a long time to get that going. The main test was not so much for sort of current infections, but rather for have you been exposed earlier? So is there an antibodies here? Herd immunity is, well, this has been a hot potato, I guess, in most countries. Is this a desirable strategic objective, or is there some really dark side to this goal? In the US, for instance, herd immunity is considered extremely controversial because people believe that, well, what herd immunity essentially implies is that we allow certain people to die in order to save the vast majority. And I don't think that is the strategy at all. You could rather think of herd immunity as perhaps allowing people who are not likely to be severely injured or unhealthy by the virus. For instance, people in their 20s or 30s or even 40s, if they come down with the virus, they are much more likely to survive that compared to people in their 60s or 70s or 80s. So you could think of herd immunity as basically saying that, well, there's only one way that we can sort of deal with that. We cannot, as one of the former state epidemiologists in Sweden, Mr. Giesecke said, it's the thought of thinking that we can all somehow avoid being, hit by this virus is entirely futile. He said, that's not going to work. So the question is rather under what circumstances and which age cohorts do we want to be exposed to the virus? So there was an extensive debate here as well. Many people were sort of critical towards the idea of herd immunity. And so the official stance by the public health authority was to say that, well, it is not a goal. We consider it a byproduct. And this was also the official stance of the state epidemiologist, Mr. Anders Tegnell. Now, if you have, I mean, I guess in this setting, as in most social settings, there can only be one alpha male. And Mr. Giesecke was the person who actually employed the current state epidemiologist. And if we consider the fact that Mr. Giesecke takes a more positive stand towards herd immunity than does Mr. Tegnell, and if you know your Star Wars, you realize that Luke Skywalker is not very likely to tell Darth Vader that, okay, I know you're my dad and all, but I strongly disagree with you on this. That's not how it works. So I would interpret Mr. Tegnell as being somewhat sort of cautious about committing himself to this particular policy goal, is because I can see Mr. Giesecke whispering in his ear that maybe we shouldn't talk about herd immunity, but we shouldn't be entirely against it either. So this is something which has been sort of coming and going in this debate. The big problems here was that the Public Health Authority did not monitor nursing homes very, very, very closely. They did not monitor the healthcare system very closely either. Under normal circumstances, there is some monitoring going on, but they did not increase the monitoring when these two, when the local authorities and the regions came under tremendous pressure during the pandemic. And this also, I think, explains in part why we saw most of the malfunctions, on this particular, the two levels. How am I doing time-wise, Paul? Okay, cool. Issues and problems. Nursing homes run by the local authorities. Protecting the old and the fragile and the vulnerable has largely failed. We had a large number of deaths in the nursing homes. And the questions have obviously been raised many, many times now. Why was this? And there's a wide variety of answers here. One is that the staff working in nursing homes were not properly trained. We can compare this, for instance, to the Norwegian nursing homes, where each nursing home actually had were sort of properly staffed by medical experts. So there was a GP there were nurses. We don't have anything like that at all. And the staff also didn't realize that if they were making the tours through the nursing home, they were ideally suited to move the virus from one person to the next, unless they wore PPEs, personal protection equipment. If they did that, they would be okay. Only problem was that there was a major shortage of such equipment, and so this is how we could see a number of nursing homes where the virus would spread very, very quickly. So it was really, really sad to watch. Travel restrictions were introduced very, very late. Again, this is something where in hindsight you can say, well, why did that have to take so long? How complicated are those decisions? They knew that there were flights coming in from the pandemic hotspot, so why not just stop those flights? Third, as you can see earlier, the strategy rested to a large extent on the fact that if you feel okay, then it's okay for you to head out into town. If you don't feel okay, you really should stay at home. And then when it over time became clear that you can feel perfectly okay yourself, and in the meantime you can well be infected, and you can also transport the virus onto other people without coming down with serious illness yourself. That was a major problem, and that was a game changer, I think, understanding that you can feel fine and you can be a major super spreader anyway. The response time in crisis management has been slow. Now, if you consider the rather complicated system of governance here with autonomous agencies, autonomous local authorities, autonomous regions, you understand that you can't really just sort of barge in and saying that and telling people in the regions and the local authorities saying that, look, I know that under normal circumstances you guys enjoy extensive autonomy, but these are not normal circumstances, and so we're going to really, here are the command rules. Here lies, I think, part of the answer to why Sweden performed differently or worse than, say, Denmark and Norway. Because what happened there was that when the scope and the mortality numbers began to increase in Denmark and Norway, the political level stepped in. They basically sort of politicized the issue, saying that no, that's not how we're going to do it. we're going to rely on extensive lockdown here. And the interesting thing is that the Swedish senior epidemiologist was really, he said, he gave this long talk over the summer in a news show. And he said that I was really surprised when I saw so many countries in Europe locking down, because that is not at all what we had agreed upon. So when the epidemiologists across Europe, in their many annual professional meetings in the European context, when they discussed how to deal with pandemics, they all agreed that no, we're not going to lock down. We're going to try to keep society open. We're going to keep the economy open. And so he said when he really freaked out when he saw country after country locking down. And he couldn't understand why. I said, this is not what we agreed upon at all. And the difference is that in those other countries, the political level stepped in and just overruled what the epidemiologists wanted to do and said, no, I see where you're coming from, but that's not how we're going to do it. We can circle back to that if you want. There are also major problems with insufficient stockpile of PPEs, of medicine, of drugs, and other equipments. That I would put down on, okay, sorry. I would put that down to too much flirting with new public management, which emphasized the just-in-time delivery. Do not keep anything on stock because stock is economically not very optimal, so you should instead focus on having things delivered just in time. That works great under normal circumstances, but when you're in an international crisis such as this one, you just head into really, really problems. I'll stop there for now.
Thank you so much, Professor. That was fantastic to get this snapshot of something that's been discussed so much over the summer and to hear the latest and your thoughts on it. I've seen a couple of questions coming through, and so I'm going to hand over to Professor Dimitris Papadimitriou now to share some of the question asking, but do keep them coming. You can use the chat function and also the Q&A function as well, should you wish to do so at the bottom. So Dimitris, over to you.
Okay, thanks very much. Jon, thank you for an excellent presentation. As usual, I will abuse my my position as chair to ask the first question. Those of our audience who are regular in our seminars, they might be familiar with this. And I'll start by making a rather peculiar, I'd say, comparison. I don't often use Greece as a success story in this seminar series, but Greece may offer an interesting case here, and I will formulate my question in a minute. Greece is a similar sized country to Sweden, about 10 million. And the number of deaths from coronavirus has been just under 600 today. Mm-hmm. During the first stage of the crisis, was a lot less. I think by the beginning of August, there were less than 200 cases where people have died from it. So there is a very interesting contrast here in a way. You wouldn't expect a country like Greece to do well in such a complex policy matter as this. Similarly, you wouldn't expect Sweden to do so badly. And one of the things that many people have talked about in the Greek case as something that has led to this successful managing of the crisis is that the crisis was managed by a very small number of people, mm-hmm. Where senior epidemiologists managed to co-opt the Greek prime minister very quickly to convince him to lock down early. And they have kept a very close rein on the management of the crisis, in many ways outside the administrative proper mm-hmm. of Greece. And that has worked, it seems to me. Now, the question for Sweden, I guess, and that's where I guess your wisdom will come very handy, is you seem to have implied that the response to the crisis was also culturally entrenched, in the sense that Swedish people value their freedom. There is a lot of emphasis on individual responsibility and so on and so forth. So is it that the policy went wrong judging from the outcome, because of cultural baggage, if you like? Or was it that agency, individuals, key policymakers got it wrong?
Well, that's a great question. Thanks. Well, I mean, one doesn't necessarily have to exclude the other, I think. I mean, the policy response could have been flawed in one way or another. I don't think that the cultural baggage itself, I can see two factors here. One could be demographics, that people who tend to be more sort of socialized into these patterns, saying that, yeah, in this country, you know, we do trust our agencies, we do trust our regions, we do trust the public sector as a whole. This is something which you are sort of socialized into. And if you're looking at people saying in their 20s, maybe they're not so socialized into that. And so they will say that, well, yeah, it's all good and well what the public authority has to say, but, or the public health authority has to say, but that's not how we're going to do it. That could well be one factor. Another factor would be what the community of people who have recently come to Sweden, because they haven't really sort of picked up those signals. So they're still socialized into another perspective on public institutions. And so when the Swedish institutions somehow seem to assume that everyone living in Sweden shares exactly those same values, and then we realize, no, hang on a minute, they really don't. There are suburbs around Gothenburg and Stockholm where, say, 85 to 90% are born outside Sweden, and they've only been here for a limited period of time. They don't know how to relate to those very subtle signals coming from government, because they are used to a much more direct language. So both the cohort and both the sort of changing sort of ethnic mix of the country, I think, may contribute to what you're saying. Then I think the policy response, I think the policy itself, as is often the case, the policy itself is probably a work of art, but it's the execution of that policy and the reliance on regions and local authorities to deliver their parts. That's where things went seriously wrong. Then
Sorry.
I just happen to know a few things about the Greek system, which I think are sort of relevant. Don't ask me how, but my impression is that the Greek public health system is more sort of centralized. It is more run strictly top down, whereas the Swedish system is more negotiated. It's more sort of debated. It is more decentralized. It is more fragmented, if you want. And I think that could also make a really big difference here. When you're in crisis management, you want a fairly hierarchical top-down system.
That's a very good point. I'll just bring in some questions from our audience here. And, it relates to this issue of fragmentation that you've mentioned. Brittany wanted to ask you to tell us a little bit more about this decentralized agency setup in Sweden. Okay. Not many people understand it. Perhaps try and use an example with how this would have perhaps affected the way in which health authorities might have reacted to COVID.
Okay, yeah. Thanks, Brittany. That is a good question, and I can understand why people who are not from this country may have problems understanding it. This is a long tradition. It goes back, I think, more than 200 years in time, that our agencies are extraordinarily autonomous. They're given a broad set of objectives. They're being funded and they're being staffed, and there is a political appointee who is at the head of those agencies. Other than that, they're just given this mission and they report at the end of the year what they've done, basically. And overall, that seems to work fairly well. But it gets really interesting when these autonomous agencies are to interact with the equally autonomous regions and local authorities. So let me give you an example. I'm doing a research project now on what is called antimicrobial resistance, which basically means that if you use too much antibiotics, there is a fair chance that we will have super bugs or super bacteria that are resistant to antibiotics. Hence, we need to reduce the consumption of antibiotics. This is a key goal for the public health authority, but most of the antibiotics come from the regions. So how do they get the regions to implement the directives? I did an interview with a senior official in the public health authority. This was in March. And I started by asking her, what would you say are the biggest challenges for you in this respect? And she responded that, well, the biggest problem, of course, is that we don't have any formal authority over the regions who distribute all these antibiotics. We have no formal authority at all over them. And then I let some time go by. And then towards the end of the interview, I sort of came back and said, why do you explain the fact that Sweden has been so successful in sort of curbing the use of antibiotics? And she said, again, without a second's doubt, said it's because we have a really great working relationship with the regions. So how do you combine these two? My point here is that sometimes a negotiated interaction is more effective than a formal authoritarian one. So this comes back to one of my favorite articles, I think, of all times, written by the American Granovetter, called "The Strength of Weak Ties." It's back from the 1970s. He basically argues that any arrangement between two parties, or even within larger social groups, that are negotiated and debated, where you arrive at a consensus and then everyone sticks to that, is more sustainable and more effective in the longer term than a formal authority stepping in and saying that, I don't care what you think, here's what we're going to do. That is not a very sustainable. And so what you get is these sort of strengths of sort of weak ties. Again, this is something that I think works better when things are sort of operating under normal circumstances. It is not a great system for sort of managing major crises.
Mm-hmm. Let me just bring in a couple more questions, because they keep on coming thick and fast. Adele is asking, why do you think that the Swedish example have not been followed by other countries with similar political cultures? I think that's an interesting puzzle. And I'll throw a second one as well, if you don't mind, Jon, from Jack, who asks about long COVID cases in Sweden, and whether there's been any evidence of that, or whether this has influenced policy there at all.
To the first question, to Adele's question, I had this really brilliant response in the back. Could you just quickly, please, could you just give me Adele's question again?
Yeah, sure. It's why the Swedish example has not been followed by other countries, perhaps with similar political culture.
Oh, I think that the original idea was, in fact, that they should all adopt the Swedish strategy. I think the only reason why Sweden came to single out as much as it did was the fact that the public health authority and the regions and the local authorities are more autonomous here than they are in, say, Denmark and Norway. And so when there was a political interference in those countries saying that we're not going to take the sort of liberal path, we're going to lock down until we know better what we're up against here. And Sweden ended up being the outlier. That was not the plan. It happened because most other countries saw strong political control saying that, no, we're not going to go down that path. That's the short answer. In terms of the long-term COVID cases, yes, there are numerous. And I think one of the big challenges now for the healthcare sector is, in fact, is not so much to treat people in the ICUs, but rather to have people who know how to rehabilitate. Some of this could well turn out to be sort of chronic health issues, which they will never fully recover from. So there are lots and lots and lots of them. Yeah.
Okay. I've got another question. I'm going to read it out because I don't really know much about it. To paraphrase it, it's from Cole. He says that the dry timber theory had been circulated in various articles and journals. If you have any knowledge of this topic, could you give your opinion on how potential previous flu years had effects on country COVID tolls, death tolls?
Right at the beginning, you said has been circulating. What has been circulating?
It's something called the dry timber theory.
The dry timber theory?
I've never heard of it before, but I don't know if perhaps it's something that...
So it has to do with the existence of previous flus, or?
Shall we perhaps ask a call to elaborate a little bit more on chat, and then I can come back to this.
Yeah.
There is a cluster of questions here that relate to the question of the relationship between experts and policymakers, which is of course a topic hotly contested in this country as well, right? So Brittany again, he says that are you saying that the decision to lock down or not has nothing to do with politics? It's a good question. And then Rosie raises a question here. He says, do you believe that listening to experts over governments should be the preferred response? And do you think that Sweden, in comparison to the UK, for example, has been more successful in their response to COVID?
Okay, let me start with Brittany. I think that overall, some of the key decisions, de facto decisions, were made within the public health authority. They were then run by the ministers, and the minister, I think, would basically sign off saying that yes, you know, if this is what you believe to be the best course of action to take, then that's where we're going. The criticism has been that the politicians became, in fact, too invisible. That they would very much have liked to have a government minister, you know, in the daily press briefings, for instance, not just the state epidemiologists and 3 or 4 other experts, but rather that there will be some political presence there, that there will be a sort of visible political leadership. And I think the absence of that has not really been good. The other question, you know, should government listen to experts more broadly? I believe they should. I believe they should. There are 2 sides to this. One is to know substantively what is the best course of action here. You know, disregard public opinion altogether. Just, you know, from your professional point of view, what do you think is the best thing for us to do? But in addition to that, there's also the accountability side, and experts are not accountable. You know, we often forget that experts are not accountable. Elected officials are. And so the elected officials has to have the final word. And I think what happened in Sweden was that the elected officials, cabinet ministers, I think they took the profile they took was probably too low. They should have sort of stepped in. They did on a couple of times, you know. They would step in and say that, yes, here's what you have to do. They would emphasize the seriousness of the situation and so on. But in terms of substantively what to do, I think that, yes, I do believe that we should listen to the experts. There are some horror stories coming from other countries, which I will not mention here, but I think we can all see what happens when you really politicize the best strategy to deal with the pandemic.
Excellent. There are more questions coming in, so I'll try and account for as many as I can. Again, Cole, an interesting question. You say, do you think it is appropriate to measure success in the way that countries deal with COVID only by reference to deaths? Or should we also, COVID-related deaths, or do we also need to account for issues like waiting list deaths or financial ruin, mental health, and so on?
Well, thank you, Cole. That is a really, really good question. I mean, this is the number that we always look at first, isn't it? The number of, you know, what is the sort of, what is today's death toll? What is this week's death toll? That's where we go first. In the longer run, you can say that, well, yeah, certainly, I mean, there are loads of factors. We need to, for instance, we need to think about what happens after the pandemic, once things begin to normalize gradually. Do these people have a job to go back to, for instance? How well can the social welfare system support families and businesses during this crisis? And there are some really good hard data on that as well, which we certainly should consider. There are also the more long-term health effects, coming back to one of the previous questions here about people who may sort of chronically suffer from the coronavirus. But we do tend to look at the mortality rate. There's a lot of justification for that, I think, because that is the most urgent, the most immediate impact of the pandemic. But I would certainly not use it as the only measure. No.
Mm-hmm. Mm-hmm. There is another question here that I'm not entirely sure what it implies, but I'm gonna try and interpret it and ask it to you. It relates to the way that Sweden responded to the refugee crisis in 2015, mm-hmm. and the way in which Sweden responded to the COVID crisis. Mm-hmm. I guess the underlying comparison here, if I'm not mistaken, and please correct me in chat if I am wrong, is that somehow Swedish decision making has gone against the grain. Sweden was one of the countries that have opened up to more refugees during the 2015 crisis, mm-hmm. Against a mainstream view in other European countries of mm-hmm. closing up. And in the case of the coronavirus, of course, the COVID crisis, a slightly different trajectory too. So it's, I'm used to hearing that Greece is an exceptionalist case, but can we perhaps say that there is something exceptional about Sweden in all of this?
Again, that's a really great question. And if these questions are coming from your students, I can only congratulate you, because there are some excellent questions here. Is there a similarity? Yeah, I've given this some thought, and my sort of off the cuff analysis here, I guess, would be that, yes, there are similarities. And in both cases, you can see that if we compare the Swedish strategy during the 2015-2016 migration crisis, what we saw was that in other countries, again, the political level would step in at a fairly early stage and saying that well, enough of this, we're sort of closing the borders now because we cannot accommodate any more refugees. And at the same time, what we saw was that in Sweden, we actually gave the National Migration Office more autonomy. So that, in fact, decisions on whether or not to grant not just a temporary residence, but in fact a permanent residence, was actually delegated from the political level to the administrative level. So there is a similarity here. Yeah, I'll stop there.
A very good point. We have another 5 minutes to go. I'd like now to pass on the floor to my colleague, Paul Tobin, for the last question.
Okay, hi everyone. Well, it's great to see you again. So, Jon, if it's okay, I'll just ask you one wrapping up kind of question about where next for Sweden, and perhaps also its relationship with Europe here. Obviously, it's very difficult to predict anything that's going to happen, but you mentioned that just in institutions have remained quite stable compared to other European countries. Do you have any inclinations from your interviews with other people about how you see the next couple of months going in Sweden or beyond, or is it just literally a week by week context right now?
Yeah, thanks, Paul. Good question. I think that what we're looking at now is somewhat more sort of micromanagement of the pandemic. I did an interview via email with Wired just a few days ago, and one of the questions that I had was that, okay, so what are the measures being taken now, and where do you see this going? And I just sent off the email to him saying that, well, I think we're going to stay pretty much where we are. And then I turned on the news and they said that, well, for the first time now we can see that the Public Health Authority is now introducing more sort of regionally targeted measures. Mm-hmm. Which we've seen in some other countries, but we haven't seen it in Sweden before. Because what has been clear, I think, from early on is the distinct sort of regional or even local character. You have one or two super spreaders and bang, there's a rapid increase, very localized. And so what the authorities are doing now is that they're looking more specifically at that. So there's the city of Uppsala, which is north of Stockholm, where there's been an unexpected spread, and it is actually becoming quite serious. And so the health authority is now issuing specific directives for that one particular county. Really, really interesting. I think we're going to see more of that. So that a more diversified strategy while maintaining the sort of the relative openness of society. In terms of the number of new cases or the death toll, I think we're in sort of pretty good shape overall. But there are these regional pockets where you see, massive growth.
And indeed, you look at Uppsala, which is most notable for being a university city, which
Exactly.
is a similar trend to some of the things we've been seeing in the UK as well most recently.
Yeah.
Just before we thank Professor Jon Pierre for so many fascinating points and speaking with us today, can I just flag up that Dr. Andy Smith from Sciences Po Bordeaux will be speaking in 2 weeks' time, same place, as it were, about French politics and also the institutions therein. So do come and join us at 2 o'clock in a fortnight's time. But for now, Professor Pierre, thank you so much for joining us at the Manchester JMCE.
This has been a real pleasure. This has been a real pleasure. So thank you, Paul, for having me.
Thank you so much.
Pleasure's ours. Thank you so much, Jon.